Hello everyone, welcome back to my channel. In our last video, we started a series on diuretics and discussed about the carbonic anhydrase inhibitors. In case you missed that video, I have added the link in the description below. Today, as we continue this diuretic series, we will discuss about the loop diuretics. So let's get started. Loop diuretics, as the name suggests, loop. So they must be acting on the loop of Henle. These loop diuretics, such as furosemide, torsemide, ethacrynic acid, they act on the thick ascending limb of loop of Henle. So the drugs which act on the diuretics which act on the thick ascending limb or thick ascending part of loop of Henle is a loop diuretic. The loop of Henle consists of a descending part, a hairpin bend, then it consists of an ascending part which is thin, then it consists of an ascending part again which is thick. This thick part is where loop diuretics act. This is the site of action of loop diuretics, thick ascending limb of loop of Henle. This descending part, it is water permeable. It allows water reabsorption because of presence of water channels. Water channels known as aquaporin. More specifically, it contains aquaporin 1. That is why it allows water reabsorption only. But if we look at the ascending part is opposite of descending part. It allows ion reabsorption. It allows reabsorption of ions but is impermeable to water. Mainly in the thick ascending limb of loop of Henle, this ion reabsorption is possible with the help of a cotransporter or symporter known as sodium potassium 2 chloride cotransporter. Sodium potassium 2 chloride cotransporter. Okay, so this sodium potassium 2 chloride cotransporter, what it does, it moves one sodium, one potassium and two chloride ions from the lumen into the cell. So one sodium, one positive charge, one potassium, so we got a 2 positive and 2 chloride 2 negatively charged. So it moves equal number of ions, 2 positive and 2 negative ions from the lumen into the cell of thick ascending limb of loop of Henle. Once this sodium, potassium and chloride gets reabsorbed, chloride exits out of the cell via the chloride channels. Then sodium moves out of the cell via the basolateral sodium potassium pump, which pumps 3 sodium out and brings in 2 potassium ions into the cell. Already cell was rich in potassium due to this sodium potassium 2 chloride cotransporter. So now the cell is getting loaded with potassium. Because of this increased concentration of potassium within the cell of thick ascending limb of loop of Henle, potassium leaks back into the lumen via the potassium leaky channels. Because of this back leak of potassium into the lumen, it creates a charge of plus 8 millivolts in the lumen. Due to this, other cations such as magnesium and calcium, they get reabsorbed via the paracellular route. In the kidney, in the nephron, there are two mechanisms of reabsorption. Number one is the transcellular. Number two is paracellular. In the transcellular route, the ion first moves from the lumen into the cell, then from the cell into the interstitium, then from the interstitium into the blood. In the paracellular route, the ions they get reabsorbed through the tight junctions which are present between the two cells, through the tight junctions and directly into the interstitial fluid. So the summary of this slide is the sodium potassium cotransporter moves one sodium, one potassium and two chloride ions from the lumen into the cell. And from there the sodium gets into the vasa recta or blood vessel via the sodium potassium pump, and chloride also gets out of the cell via the chloride channels. Because of the sodium potassium ATPases or sodium potassium pump, the cell gets loaded with potassium. Already it was loaded with potassium because of this cotransporter. Due to this increased quantity of potassium within the cell, the potassium leaks out or back leaks into the lumen, which creates a charge of +8 millivolts in the lumen. Because of this excessive positive charge, other positively charged ions such as magnesium and calcium, they get reabsorbed via the paracellular route through tight junctions. So if we talk about loop diuretics, the loop diuretic, they act on thick ascending limb of loop of Henle. In the thick ascending limb of loop of Henle, they block or inhibit this cotransporter. So the loop diuretics, they block or inhibit this sodium potassium 2 chloride cotransporter. Once this cotransporter is blocked, so no sodium, no potassium or no chloride will be reabsorbed. So more and more ions will remain in the lumen. Once ions will not be reabsorbed, so they will not be reabsorbed, so the interstitium will become hypoosmolar. So the concentration of solutes within the interstitium decreases. As the concentration of interstitium decreases, the medullary interstitium becomes less hyperosmotic, so the kidneys lose its ability to concentrate the urine. Even if antidiuretic hormone is secreted in the last part of the nephron, the kidneys will not be able to concentrate the urine. So let me show you. So this is the thick ascending limb of loop of Henle. Once ions get reabsorbed via the sodium potassium 2 chloride cotransporter, this area becomes hyperosmotic. Once this area becomes hyperosmotic, the last part of the nephron then reabsorbs water. Once we block this sodium potassium 2 chloride cotransporter, the medullary interstitium becomes less hyperosmolar. Once it becomes less hyperosmolar, so the last part of the nephron now will not be able to reabsorb the water, so it will lead to diuresis, massive diuresis. Number 1. Number 2, since more and more salt and ions remain in the thick ascending limb of loop of Henle, as we know, water follows the sodium, so more and more water will remain in the lumen. This again will lead to diuresis. That is why it is said that these loop diuretics, they are very powerful diuretics. So the main mechanism behind diuresis is that once the sodium potassium 2 chloride cotransporter is inhibited or blocked, the reabsorption of these ions stops, the medullary interstitium becomes less hyperosmotic, so the kidney loses its ability to concentrate the urine. As the result, free water reabsorption decreases, leading to increased urine volume. that is diuresis. In addition, since sodium and other solute remain in the tubular fluid, the osmotic pressure inside this lumen increases, which results in more water in the lumen. This is the main mechanism or explanation behind the powerful diuresis. So, once this was blocked, no sodium, no potassium, no chloride was reabsorbed, which led to increased or powerful diuresis. Once this is blocked, this cotransporter is blocked, so potassium will not back leak into the lumen. This plus 8 millivolt gradient will also not be created. Once this gradient will not be created, magnesium and calcium will not be reabsorbed via the paracellular route. That is why, along with the natriuresis, along with the diuresis, this magnesium also leaks out with the urine, this calcium also leaks out with urine. Okay, now after this, now within the lumen of thick ascending limb of loop of Henle, there is increased load of sodium and other ions such as potassium, chloride, there is calcium, there is magnesium in the lumen of the thick ascending limb of loop of Henle. As this fluid now moves forward, it reaches the last part of the nephron, that is the collecting duct or the late distal convoluted tubule. So within the cells, the principal cells, what they do, they as they see more than normal level of sodium, they start reabsorbing sodium. Okay, they start reabsorbing sodium via the epithelial sodium channels. Once the sodium level increases inside the cell, it is thrown out of the cell and then finally into the interstitium and into the blood vessel via the sodium potassium pump. Via the sodium potassium pump. So the cell again gets low. Now the cell gets loaded with potassium. Because potassium level increases within the cell, this potassium back leaks into the lumen. Already in our lumen there was sodium, there was potassium because of the sodium potassium 2 chloride cotransporter inhibition, there was chloride, there was magnesium, there was calcium. Now again more potassium will leak out with urine. That is why it is also, this loop diuretic is known as potassium waster. They lead to caliuresis as well. So finally the effect of loop diuretic is it causes natriuresis, it causes massive diuresis, then caliuresis. They are potassium wasters as well, just like carbonic anhydrase inhibitor. They cause chloride loss with urine, magnesium loss with urine, and calcium loss with urine. Now, when should we use, or what are the indication or clinical uses of loop diuretics? If there is edema, whether that edema is due to congestive heart failure, or that edema is due to nephrotic syndrome, or that edema is due to cirrhosis, or if it is pulmonary edema, loop diuretics are given. In case of pulmonary edema, for symptomatic or rapid relief, loop diuretics are drug of choice. In case of resistant hypertension, resistant cases of hypertension, we also give loop diuretics. Then if a patient is having hypercalcemia, we also prescribe the loop diuretics. Why? Because they excrete out calcium with urine. But care must be taken to always prescribe it with 0.9% normal saline, because since they are powerful they cause powerful diuresis, it can lead to volume depletion, dehydration as well. It can lead to hypovolemia as well as hypotension. In case of hyperkalemia also, it can be used. These loop diuretics can also be used because they are potassium wasters as well. So next we will talk about adverse effects. The adverse effects are usually because of the electrolyte imbalance caused by loop diuretics. It causes hyponatremia because natriuresis occurs. It causes hypokalemia because it leads to kaliuresis. They are potassium wasters. It causes low levels of magnesium chloride as well as it causes low levels of calcium. Since it is a powerful diuretic, loop diuretic, it can lead to dehydration, uh, excessive dehydration can lead to hypovolemia, hypotension, and sometimes if it is over if it is given in large doses, it can lead to pre-renal azotemia as well. It can cause damage to the kidney. It can lead to the pre-renal azotemia, or we can say pre-renal acute kidney injury can also occur because it is a powerful diuretic. Then it can also lead to ototoxicity. Why? Especially if there is ethacrynic acid or if it is combined with other aminoglycoside antibiotics. Why it causes ototoxicity? Because it not only blocks the sodium potassium 2 chloride cotransporter in the kidney, but it also blocks the sodium potassium 2 chloride cotransporter or symport in the stria vascularis. This stria vascularis is a structure within the inner ear. So it blocks cotransporter in the stria vascularis of the inner ear. Once this cotransporter is blocked, the ionic composition of the endolith is disturbed, which can lead to hearing loss, tinnitus, or vertigo. It can also lead to allergies, particularly if particularly so allergies. Why these allergies are developed? Because these are sulfonamide derivatives. These loop diuretics, they are sulfonamide derivatives. They are sulfonamide derivatives. That means they are the compound that contains sulfonamide group. This group is derived from sulfonic acid and ammonia or amines. So we have antibiotics such as sulfa antibiotics. We have anti-diabetic or oral hypoglycemic agents such as sulfonylureas, and then we have these loop diuretics. They are all sulfonamide derivatives. If a person is having sulfonamide allergy, it can lead to rash, eosinophilia, but this ethacrynic acid, this is not a sulfonamide derivative. So in case of allergy, sulfa drug allergy, we can prescribe ethacrynic acid. Then if we talk about different types of diuretics, we have furosemide. It is very common. It is a short acting drug. Then we have torsemide, longer duration, better oral absorption. Then we have bumetanide. It is more potent, but it is less commonly used. Then we have ethacrynic acid. As I mentioned, it doesn't contain any sulfa group, but most ototoxic. Then there is a disease, there is a syndrome which mimics the chronic loop diuretic use. It is an inherited disorder. It is a very rare disorder in which the thick ascending limb of loop of Henle is affected. What happens in Bartter syndrome? The sodium potassium 2 chloride, which is a loop diuretic sensitive cotransporter, is there is a defect in it. There is a defect in the potassium channels, leaky channel. Then there is defect in the chloride channel. Actually, if this is the sodium potassium 2 chloride cotransporter defect in this, then we have chloride channels through which chloride exits and then gets reabsorbed. This is also having some problem. That's why they are not able to work properly. And then we have these potassium leaky channels. They are also not working, functioning very well. That is why these patients have effects similar to those of loop diuretic. So that means they must be having increased urination, that is polyuria. They have polydipsia, they drink a lot, they have salt craving because that is getting excreted out with urine, and these patients have growth retardation as well. If you want a detailed video on Bartter syndrome, just drop a comment. I will make a detailed video on Bartter syndrome. So when is it contraindicated, or when should we take precautions when we are prescribing loop diuretics? If a patient is having severe hypokalemia, these loop diuretics must be avoided, because why? They are potassium wasters. They can lead to severe hypokalemia. In patients with severe hypokalemia, they can cause life-threatening arrhythmias because of low potassium. They can further worsen the hypokalemia. If a patient is dehydrated, or if he is in hypotension, then again they are avoided. If a patient is having sulfa allergy, in case of sulfa allergy, all the loop diuretics are contraindicated except ethacrynic acid. In case of renal failure, they should be prescribed very cautiously, because renal failure increases the risk of ototoxicity. So let's summarize what we have studied up till now. Loop diuretics, how they work: they act on thick ascending limb of loop of Henle by inhibiting the sodium potassium 2 chloride cotransporter. They lead to natriuresis, massive diuresis, kaliuresis, chloride loss with urine, magnesium loss with urine, and calcium loss with urine. They are used to treat conditions of edema. That edema may be due to congestive cardiac failure, it may be due to liver cirrhosis, or it may be due to nephrotic syndrome, or it is used in pulmonary edema, it is used in resistant hypertension, or we can also use in hyperkalemia and hypercalcemia. But care must be taken that we should always prescribe it with 0.9% normal saline to prevent volume depletion or hypovolemia. So talking about the adverse effects, it can electrolyte imbalance, dehydration, ototoxicity, allergy, particularly with other like furosemide, torsemide, but not with ethacrynic acid, because it is not a sulfa derivative. Then we discussed about Bartter syndrome, that it resembles the effects of the Bartter syndrome, they resemble the chronic loop diuretic usage. So if you found this video helpful, please give it a like, share it with your friends, and subscribe to my channel. So the next video will be about thiazide diuretics. Thiazide diuretics. Thank you for watching. Happy learning.